Question. A 67-year-old man with a history of hypertension and type 2 diabetes presents to the emergency department with sudden onset right-sided weakness and slurred speech that began 45 minutes ago. On examination. BP, 180/100 mmHg. HR, 88 BPM. Neurological exam. Right-sided hemiparesis. Facial droop, dysarthria. Non-contrast CT brain. No hemorrhage. Which of the following is the best next step in management? A. Administer aspirin immediately. B. Lower blood pressure to 140/90 mmHg before treatment. C. Administer intravenous alteplase, TPA. D. Perform emergency thrombectomy. E. Start dual antiplatelet therapy, aspirin plus clopidogrel. Correct answer is C. Administer intravenous alteplase, TPA. This patient presents with acute ischemic stroke, right-sided hemiparesis, facial droop, and dysarthria, within the golden window for thrombolysis, less than 4.5 hours from symptom onset. Since his CT brain shows no hemorrhage, the best next step is to administer intravenous alteplase, TPA, to dissolve the clot and restore blood flow. Why not the other options? A. Administer aspirin immediately, incorrect. Aspirin is the standard treatment for ischemic stroke, but it should be given only after ruling out eligibility for TPA. Giving aspirin before TPA increases the risk of bleeding. B. Lower blood pressure to 140/90 mmHg before treatment, incorrect. In acute stroke, BP should only be lowered if it exceeds 185/110 mmHg before giving TPA. This patient's BP is 180/100, which is within the acceptable range for thrombolysis. D. Perform emergency thrombectomy, incorrect. Thrombectomy is used for large vessel occlusions, e.g., MCA stroke, but it is reserved for patients who either are not eligible for TPA or who have persistent occlusion post-TPA. E. Start dual antiplatelet therapy, aspirin plus clopidogrel, incorrect. Dual antiplatelet therapy is used for mild strokes and transient ischemic attacks, TIAs, not for major strokes needing TPA. Key learning points. Stroke thrombolysis criteria, TPA eligibility. Symptom onset within 4.5 hours. Non-contrast CT shows no hemorrhage. BP 185/110 mmHg, lower with 4-labetalol if needed. No recent surgery, bleeding disorder, or anticoagulant use. Blood pressure considerations before TPA. If BP is less than or equal to 185/110 mmHg, TPA can be given. If BP is above 185/110 mmHg, lower it first with 4-labetalol or nicardipine. After TPA administration, avoid antiplatelets, aspirin, clopidogrel, and anticoagulants for 24 hours. Monitor for signs of intracranial hemorrhage, worsening neurological status, headache, vomiting.